The key aspects, I think, in thinking about patients who have advanced disease is that we are now in an era with current DAA therapies with the vast majority of patients are going to be successfully cured. That's a dramatic change from not very long ago with where we didn't even offer treatment to somebody who had decompensated disease. The treatments are well tolerated and safe. And as I'm going to show you, most patients will derive important clinical benefits, including reduced risk of liver-related complications and improved liver-related and overall survival. So lots of reasons for us to consider treatment. These are data from the interferon era, but there's no reason to think they won't be often as we look 5 years from now at our DAA experience. It's really to show the dramatic improvement in overall mortality in patients with compensated cirrhosis. So this is kind of one end of the spectrum of patients that we see. And when somebody's cured now who has cirrhosis, we can say to them that they have approximately a 75% reduction in their risk of liver-related and overall mortality by the achievement of SVR. And this is a slide you've all seen very well, and it's not just related to the prevention of death, but also liver cancer, I think, is an important aspect of what we can do in terms of treating patients with cirrhosis. Now, do we have similar data for decompensated disease where we look at people 5 years later? The answer is no. And that in part sort of kind of plays to why we have some challenges, I think, in sort of making decisions about kind of risk-benefit in the decompensated patient. But without doubt, compensated cirrhotics benefit from therapy. And when we think about the patient with advanced disease, which is the topic I'm to cover, it's a very wide spectrum. At one end, we have the compensated cirrhotic child A, low MEL score, maybe has HCC as an indication for liver transplant. And in that patient, we have more DAA therapies to choose from. The chance for SVR is very high likelihood those individuals derive clinical benefit, and ultimately, I think they're likely to be cured before they die of a liver-related complication. And on the opposite end of the spectrum is the advanced decompensated cirrhotic patient who's got child C disease, may have severe or refractory portal hypertensive complications. In that group of patients, we have fewer DAA options. There's a modest reduction in the SVR rates as they have more advanced disease, as I'll show you. In this group, the risk of dying before or with an SVR is much higher. And I think this is where the clinical benefits, in the short term, I think we understand that, but I think beyond sort of the 6-month mark, it's difficult to know what the benefits are. And then the Child's B, the sort of group in between, I think, kind of characteristics of both. But when talking about treatment of patients with advanced liver disease, I'm trying to encompass this entire spectrum, and I think that's kind of in part where the challenge is. So if we shift now from a compensated cirrhotic to decompensated, I think the kind of themes here are that the SVR rates are slightly reduced. If you look at Child's A results, overall it's about 95% SVR. When you move to a Child's BC cirrhotic, it's in the 80 to 90% range. And for some genotypes, it's even lower than that. Tolerability and safety, although very good, I think we need to be a little bit more careful, and greater scrutiny of events that occur when people are being treated needs to be done. And the problem of concurrent renal dysfunction, I think, then can be actually limiting to therapies. So often our patients with advanced decompensated disease are the group that are at risk for also getting hepatorenal or pre-renal dysfunction, therefore really limit our options. If you have a patient who's got decompensated disease and has renal dysfunction with a creatinine clearance less than 30, today there's still no treatments for those patients. And then what we don't know yet is the consequences of treatment failure. And by that I mean development of RAVs, for example, the consequences of having a relapse, whether that might be greater in somebody who's got more advanced disease than in a compensated cirrhotic. And I think the really kind of controversial area is really trying to consider treatment in the context of liver transplant. And what often is talked about is MEL purgatory. I'm not going to really speak to that. I think that's going to be covered later. But to recognize that when we treat somebody who's on the wait list, this issue of what do we do when we get improvements in terms of their access to transplant is a very, very topical decision. So just to review the drug options, these are all very well known to you, but just to point out that really in a decompensated setting, we're talking about sivosavir with an NS5A inhibitor. And because they're all sivosavir-based, if you have an individual with renal dysfunction, there are no therapeutic options. So to recap, and you've seen this many times, I'm just really going to highlight a few things about the data. So first and foremost, for decompensated cirrhotics, a common theme is that we add ribavirin. It's clear that that adds something in terms of achieving SVR. And so most of the trials, even with new therapies that are, for example, expected later in this year, when they tested them in decompensated cirrhotic patients, indeed, we find that ribavirin continues to emerge as an important component of the therapy, probably as important or perhaps more important than the duration of therapy. So that's the first theme. And overall SVR rates, as I pointed out, sort of in the 80 to 85% range in Child's BC cirrhotics. Now, the other thing to note about these results is when you quote an SVR rate in decompensated cirrhotics, you're capturing both the failure rate of therapy, but you're also capturing deaths. So there's always this competing risk of death in individuals with decompensated cirrhosis. So sometimes the SVR rates look less, but it's partially because they're including deaths as well. So that if you look at the actual relapse rates for these therapies, they're not so strikingly different than what we see with patients who have cirrhosis, that it's compensated. Now, not all therapies appear to kind of be, maybe do as well across the spectrum of Child-Pugh disease. So this is just to show you data with Valpatosphere, decomposite, and ribavirin. Here you'll see there's a little bit more of a differential as we look from a Child's B to a Child's C cirrhotic. Looks like the Child's C have a much lower rate of SVR. In this particular study, there were no deaths, so we can't sort of ascribe this lower response rate in Child-Pugh C to deaths. But keep in mind here that the number of patients actually studied is quite small. And in fact, if you look across all of the studies being done in Child-Pugh C disease, it's actually a really very modest number of patients. So I don't think we really have accurate assessments of what the SVR rate is in that group of patients. And then just to highlight the genotype 3 decompensated cirrhotics are in particular an important group where I think we do need more therapies. This is data from the UK Expanded Access Program. I think gives us very nice data looking at NS5As with Valpatosphere and decompensated genotype 3 patients. These were all treated for 12 weeks, and you can see that they had either treatment with or without ribavirin. Most got ribavirin, in fact. And it shows here that decomposite Valpatosphere plus ribavirin actually, with or without ribavirin, was better than soft Delisting. But overall, you can see the SVR rates in the genotype 3 patients are more in the 70% range. So again, a notch down from what we saw with genotype 1 patients. Now, we always are looking to the future to say, well, something else better might be right around the corner. And of course, we're expecting the approval of soft valpatosphere perhaps later this year. And this is the data that was presented on Astro 4. And just to make the point again, that ribavirin is still an important component of this therapy. So that's the red bar is soft valpatosphere with ribavirin. And in each of the treatment groups, it actually performs better than soft val without ribavirin or even soft val given for 24 weeks. And that's particularly true for the genotype 3 patients. So again, I'm making the point, ribavirin is going to be part of the cocktail for decompensated cirrhotics. And again, while this therapy offers something better, I think, for genotype 3 patients, genotype 3 still remain probably our most difficult to treat decompensated patient. Now, turning to safety, I've already emphasized that one of the challenges in looking at decompensated disease and the safety data is that there's a lot of serious adverse events that happen and are recorded. And this is just one, again, from the Expanded Access Program. Just to point out, a lot of events, all of them typically ascribed by the investigators to their disease as opposed to a complication of their underlying treatment. But I'll just make the point that you have no control group, it's very difficult to discern if something is caused by the treatment versus just the natural history. There are a few data to help us there. So there was one control trial that was published where they actually were looking at SimSoft. And in that study, they showed that the adverse event rate was not higher in patients who were on treatment, suggesting indeed that it reflected the underlying natural history of the disease. But just so that we remember that we should be vigilant about new and unexpected side effects, there was a very recent publication in Journal of Hepatology about lactic acidosis that occurred in 14% of patients who were on a soft-based therapy. Most were also on ribavirin, I'll point out. Again, in this case, they didn't have a control population, but they did look at the patients in the preceding equal duration of 6 months before they went on treatment and showed that there was no lactic acidosis then, and then they developed in 15% of patients lactic acidosis on therapy. And we know that many of the nucleoside analogs are potentially a risk for this. And it's really to make the point that we need to be vigilant. These are really populations in which concurrent liver and renal disease may contribute to greater toxicity than what is seen in some of the clinical trials. So the question I was really posed was who with advanced disease should be treated. And I'm going to make the point that I think every patient with a reasonably high chance of achieving SVR, so has benefit in that regard, and of surviving beyond SVR is the group that we should be targeting. So the flip side of that is, based on that sort of global statement, who shouldn't be treated? And these are not absolutes, but I would say that on the one side, the group that's not likely to get SVR are groups that can't tolerate ribavirin, because that seems to be quite important in terms of our SVR rates. We have more and more NS5A failures, and I'm not sure that's a particularly great group to be offering treatment to, because we have very little to offer, especially when PIs can't be used. Maybe high-level resistant RAVs might be another group in which we should be a little bit more cautious. Certainly renal failure, given the need for valpatosphere. And probably the other aspect of sort of not having a high chance of getting SVR is a very short time to transplant, although treating through transplant, I think, is still an interesting and important option. On the flip side is really the group that's not likely to survive beyond their SVR. So you could argue that there's not a lot of benefit if you can't survive beyond SVR. And who are those patients? Well, I think there are those with advanced HEC, so we see this all the time. Serious comorbidities that will be life-threatening before their liver disease. And the group that really is giving us the most challenge is this advanced decompensated group. So is there any benefit in treating those patients that were at the more severe end of the spectrum? That, I think, is really kind of the question that I ask myself every day in clinic, and I think really where we are needing more data. And I think to try to make a decision about should we treat the patients with more advanced decompensated disease is really to look at what's the timeline for improvement in these patients. These are data from SOLAR 1 and 2 compiled and presented by Ed Gain at the recent FAASLD meeting. And now we're looking at that SOLAR group now 24 weeks post-SVR. So initially we saw 12-week data, now we're looking at 24-week data. And the message here is that the longer you go out without, and survive, the more likely it is you're going to see patients that end up with improvement. So this shows us that the overwhelming number of patients get better. That group that is getting worse, that red part, is now much smaller than it was at the week 12 mark. And very specifically, if you look at Chiles-Pugh score, so if you look at the Chiles-Pugh C patients, our sort of most advanced disease, 60% of these patients improved to a Chiles B, of those that improved, and 12% actually improved to the point of a Chiles A. That might be the patient that actually is literally going to avoid all of the complications related to liver transplantation. So this is really, I think, very hopeful data that says if you just give them time, if they survive long enough, you're going to see them get better. Looking now at the MEL score, as sort of, because that's what we use typically on the transplant list, again, very similar data. Overwhelmingly, the majority of patients improve. The other message here, though, is the higher your MEL score when you're treated, the more likely you are to be in the improvement group. And some of the improvements in terms of drop in MEL score are going into the double digits now in these patients that are followed 24 weeks out. So not only are we seeing most improve, but the magnitude of the improvement is actually quite striking as well. Now, these are data that Audrey Coley presented at the AASLD last year. I'm just going to re-present it to you just to remind you. This is also a very nice paper looking at their multi-center experience with patients on the waiting list. But they have the spectrum of Chiles A through C. And what they looked at here is they treated and then they looked at whether they developed a complete response, which they defined as having a total bilirubin less than 2, an INR less than 1.2, albumin greater than 3.5 without ascites or hepatic encephalopathy, basically a Chiles A, solid. And what you can see is in the cirrhotic group, which is, I think, the group most interest to us, that 72% of the people, so overall, if those that achieved this complete response, so about a third of them had a complete response, most of those were Chiles A, which is not surprising. They didn't have very far to go. But they did have about a quarter of the Chiles-Pugh B and C patients that also had a complete response. And this was the mean follow-up of about 68 weeks. So now setting that treatment time out about a year from the time of treatment. So the longer we go out, the more we're seeing some of these patients reverse and improve. And then ultimately, like the point of improving to delisting, I think is most interesting. And again, the experience from the same paper by the French group said 18% could be delisted. And at the meeting here today, I saw another group from Spain that also has looked at their rate of delisting. And I didn't have a lot of details in the abstract, but they have approximately the same number, 20% were delisted. So 1 out of every 5 of our patients may achieve delisting in association with treatment. So ultimately, I think we can see that many will benefit, and some of them very profoundly. So the question is, can we predict who are going to be the people who do well? Because those maybe be the people we treat, and then the others maybe we would just defer, maybe do it post-transplant. So these are data sort of trying to get at that. So this is an interesting study that suggests that Chiles-Pugh score is probably better than MELD or platelet count, or any of the individual elements of MELD in predicting who's likely to respond. And a Chiles-Pugh score of about 7.5, so sort of over that, less likely to get a complete response than those under. So that's sort of one clue. There's also data that are trying to get at the issue, well, if you can't predict who's going to do well, can you predict who's going to get harm? And that's generally people who are going to get worse before they get better. And there are some data pointing towards the clues there. One is high bilirubins, presence of hepatic encephalopathy, which may be a marker of severity of portal hypertension, age, low albumin, and low sodium. But none of these studies actually have these come out as being the strong predictors that we could sort of apply clinically, but giving us a hint, I think. So the second question I was asked is there a point of no return? And I'd say yes, probably. And I think the issue here is it's really patients who have insufficient time to improve, meaning they get worse, another decompensating event before they can have an opportunity to get the benefits of therapy. And then there's probably a group in which they really don't have the reserve to recover or repair. They really, no matter how much time they get, they're going to still have advanced disease and complications that are not going to reverse. And we right now are not very good at identifying those two groups of patients, I would say. But as we look to the literature that's coming out, I think some of the clues might tell us about how we need to think about looking at this. So this idea that older age patients don't kind of reverse or have more harm related to treatment may be reflective of this regenerative capacity of a patient who's had SVR. Probably the significance of the portal, how significant or severe the portal systemic shunting is, might be relevant because maybe that won't get better if you get cure. And then ultimately the severity of the liver synthetic function. All of those things I think really just tell us we need better tools to evaluate our patients so that we can identify those that are not going to get better. So do I have an answer? Not really, but what I'd say is kind of where I would sort of see things falling out based on data so far. Going back to my spectrum of disease, is for the compensated cirrhotic, I think there's no question you should just treat them all. That's my opinion. They have all the benefits and very little risk. On the flip side, the very advanced decompensated cirrhotic, I'm going to put the Chiles-Pugh C, maybe MALS over 20, I'm not sure what the number is, the group that has significant renal dysfunction. Probably the answer there is not to treat those patients unless transplantation is not an option for them. Because I think perhaps those individuals may not have sufficient time to get better and may be better served by moving towards transplant. And then the sort of interesting group for me is the one in the middle, and that's sort of where the cutoffs are there. But I think there definitely are decompensated cirrhotics, Chiles-Pugh B certainly, maybe those with less severe portal hypertension, where you can expect that you'll get successful treatment and that you'll get reversal and potentially reversal to the point of that individual not being at risk for the liver-related complications. And the things we'll have to think about as we look at which patients to treat in that bucket of patients is maybe their age, their severity of portal hypertensive complications, and possibly severity of necroinflammation, size of liver. There's so many things that we haven't even looked at yet that might be helpful clues in terms of deciding who we should treat. But at least at the moment, I think this is where the field stands. Thank you.